Thank you for joining Let's Meet Where We Eat, conversations with innovation and entrepreneurship leaders who specialize in food and nutrition. Our series is presented by Nourish Cafe and the Food and Nutrition Innovation Institute at the Tufts Friedman School for Nutrition Science and Policy. Enjoy.
Oh, hello, people. Thank you so much for coming. I am a Tufts alum. Literally, my favorite place on the planet is Tufts, and I owe so much to it. And I come to you not just as a PhD nutritionist and not just as a chef, but as someone who has had cancer several times. And that gives me a very fierce devotion and passion for the patient side of things. So if I ever come off angry, know that I'm so very passionate about the patient's side of things that I'm not. I just want us to see the other half of things. And so I'm going to talk a little bit. I'm going to give you an amuse-bouche. I'm going to tempt your palate before we go into the main course. And then Emma's going to present what the food providers told us with our statewide needs assessment, and Katina's going to go into the community health workers. So I want you, if you're old enough, to think about 1994. In 1990, because we have a crystal ball for food as medicine, and we've got a lot to learn from what happened to what was considered alternative medicine, then became complementary alternative medicine, and then changed, finally grew up and decided it was going to be complementary and integrative health. It took 22 years. So I know in food as medicine, we're like, is it food is medicine? Is it food as medicine? Is it nutrition medicine? I've seen food insecurity kind of leave the space temporarily because it has to do with cost. And so one of the things I'd like to have you all consider is that our name is going to change. And with it, we're going to hone in our mission, our vision, and our passion. And that the patient's voice is the North Star. I'm hoping when you leave today, you see the patient not as the problem, but as the solution. Practicing for 30 years as a public health nutritionist, I have not seen chronic health disease decrease, nor have I seen an appreciable increase in fruit and vegetable consumption and healthy food consumption. So we're missing something. And today we're going to present to you what we think is the missing piece. Now, in 1994, I was almost completing my PhD in nutrition when I was diagnosed and given 2 weeks to live with a lymphoma. I got myself to Washington, D.C., where I met the amazing Dr. Freddie Cronenberg, and she hired me on the spot to open the first complementary alternative medicine program at the College of Physicians and Surgeons at Columbia University. We were the first CAM center. And what we learned was that for the first year, doctors picketed us. They thought we were snake oil salesmen, and they wanted us to go away. And then what ended up happening, probably about a year later, they came to us and they said, I want to be the herbalist. I want to be the acupuncturist. Please train us. And we did. And then about 7 years later, they came back and they said, I don't have time for this. I don't have time in my practice to be the herbalist, to be the acupuncturist. But what happened in that transition, which is why I love seeing our dietitians and our clinicians learning culinary medicine, is because that's when it became true. That's when they learned it wasn't snake oil. Not to say there weren't any snake oil in the bunch, but that it wasn't snake oil, that it does have this power. And I'm hoping when clinicians learn about transforming healthy food into craveable bites, they will see the power of culinary medicine and no longer see it as a side item, but as a foundational element. All right. And if you ask me how I survived, there's two things I know for sure. One, I have no idea what it was that I took that helped me survive. But number two, what I know helped me survive was my agency to choose my healing journey. So please remember that. There is so much power in a patient's agency to choose what direction they go in. This is the talk today. This is the foundational element. On the left, we have the healthcare sphere where we're paying a lot of attention, and rightly so. What's the ROI? What's the dose? What's the duration of food as medicine interventions? When a patient enters that space, they know I'm not the expert in this. I'm going to meet with the expert, my doctor, my dietitian, to diagnose me and to tell me what my prescription is. And then I leave and I have no freaking clue what I'm going to do. When you say something like eat more fruits and vegetables or lower your fat, there are so many elements that a patient needs to learn to do in that space that they implode. There's too much information. And they're not making those changes at the clinic. They're making it in their community and in their homes. And please listen to this, please. The patient is the expert of what goes in their mouth. They are the expert. And unless we see both sides as being experts and we connect them with both valuing the other side, I can tell you with 30 years of experience, we will never nudge chronic disease and healthful diet consumption. And I'd be remiss if I didn't talk about food. Now, my least favorite saying is that Hippocrates is the one who invented food as medicine. He did not. Actually, every woman, every indigenous person knew food to be medicine before we even had agriculture. They knew it from the beginning of time. It didn't need to take a physician to say it was true for it to be true. We've been cooking with fire for a million years, people. We took cooking vessels until 15,000 years ago. But where we learned how to cook, how to prepare the food, what to eat in our environment, came in the community setting within our tribes, within our communities, within our families. We never had other coming in and saying, this is how you need to cook your food, or this is what you need to eat. What we choose to put in our mouth is sacred. And you just need to go to any elementary school and try and take cupcakes out of the rotation, and you will have every lawyer in that school defending the right to be able to eat cupcakes. And the reason for this passion is because it's a person's right to decide what goes in their bodies. And my goal is to take eating broccoli from the left-sided picture to the right-sided picture. We can make craveable, delicious, healthful food. And now I'm going to talk about the year-long Food is Medicine Unmet Needs Analysis in Vermont, a rural state. We had two levels of inquiry. We first started with surveys to clinicians and food providers to ask them the nitty-gritty. What is it that you are prescribing? What is it that you're serving? Or is the food local? Who's paying for this? What are the barriers? And then that informed the next stage. The next step was, I'm going to call them focus groups for right now, but they are a certain type of focus group built by the co-founder of value-based medicine. They're called experience groups. And within experience groups, you allow the individual, the clinician, the patient, the dietitian to think outside the way the Western medicine system is set up. That's where you get innovation. And so we had many focus groups with dietitians, clinicians, community health workers, and food providers. There is a very long report, and if you email me, I'd be happy to share it with you. And now I'm going to pass it on to Emma, who's going to talk about what the food providers told us.
Thank you so much, Deb. Hi, everyone. I am Emma Heilman. I work as a program director at the Vermont Farmers Food Center in Rutland. We are a local food hub. You can go to the next slide, Deb. So I'm here to both represent Rutland and then also do my best to represent this data from all of these 16 food providers. We also operate and work with other programs in the state. There is a community of practice called the CSA and Healthcare Community of Practice that started in late 2022. This is comprised of 5 programs that work with this model. CSA stands for Community Supported Agriculture. So all of us work with local farms and our healthcare systems to provide produce prescription programs. So of those 5 programs, that just represents a portion of the 16 food providers. Some of the others included community food pantries, churches, others that are providing food. All of the CSA and healthcare programs were fully local. And then a majority of the other programs participated in some type of local food program. And overall, Vermont really has a big focus on our local farms. We're a pretty rural state. We valued our small local farms for a long time in this state. And we're really excited here in Rutland. We started in 2015 with our Produce Prescription program. And this year we will reach $500,000 that have gone directly into about 20 of our small local farms here in the county. And then also with these programs, the education that we're able to provide varies widely. It's really dependent on the food hub or the provider, the community partners involved, the funding. In Rutland, we put a recipe in all of our newsletters, and we try and partner with as many community organizations that are doing some sort of healthy food education as much as possible. But there's also some challenges within this work. When you're dealing with local food in the Northeast, seasonality is a big challenge. Transportation of the food is a big challenge. And really, we are the ones funding these programs. And we are the essential partners in delivery of food as medicine here in the state. Most of us are coming from more agricultural backgrounds or food systems backgrounds when we're working in this food hub setting. Yet we are trying to fill roles in these food as medicine programs that we're not trained for, we really don't have capacity for, and they won't provide the best outcomes for our food as medicine patients. So we really are delivering the food, it's essential, but we're not really responsible for the outcomes. And 92% of the produce prescription were produce prescription programs. There's not a lot of medically tailored meals happening in the state right now. We also see a high demand and high wait list with all of our programs. Most of us know that behavior change does not happen overnight. It happens with consistent support. And in this work, there are very limited feedback loops. So once we have the bag going out to our patients, we really don't see what happens. Most of our programs do try to aggregate our data. We have pre and post surveys. Sometimes those are completely anonymous, so we can get some aggregated data back from our participants, but it's really hard to follow up with every patient. And just for instance, in Rutland alone, I work part-time on this program, and we have 225 patients who are enrolled every year. So there is absolutely no way that I can follow up with each of these patients in the program. Also, we don't have the ability to know what's happening in the kitchen. Like we said, we don't know what's happening in the home. We don't know what tools are at their disposal in their kitchen, what their home situation is like. And this wide spectrum of education is needed. We have several folks who are enrolled where really the barrier to them eating their vegetables is purely financial. They know how to use the vegetables, they love them, they have family recipes, they have all the tools that they need in their tool belt, they just really can't afford it. And then on the opposite end of the spectrum, we've had folks who really have never even seen a head of lettuce in their kitchen. They don't know what to do with it. We had one woman who was putting it in her cupboard. She did not know that it needed to be in the fridge. Obviously, she did not eat it because it spoiled very quickly. So there's just a really wide spectrum of education that is needed and personalization. And then lastly, we are really being kind of pulled into this medical space without the support that is needed. We have a lot of questions and situations that come up on a weekly basis that we're really not equipped to handle. And a lot of our programs, because we are food hubs who are already in the nonprofit realm and struggling to make ourselves financially viable, we rely on a lot of interns and volunteers to help run our programs. Here in Rutland, we have 2 volunteers who go on a home delivery route every week to about 35 to 40 patients. And they are coming back to us, our interns are coming back to us with questions that they don't know the answers to, situations that might make them uncomfortable because they want to help the person and they don't know what resources or what the boundaries are. And as Deb mentioned, food is sensitive. We love food. We need food. It's really personal to the person. I happen to have a master's in social work, so I have felt a little bit more equipped in this role when these situations arise. But for instance, I was talking with one woman a few years ago in a private conversation, one of our participants, and she was able to make the connection between her childhood traumatic event and her entire 50 years of relationship with food. And that was a really powerful moment for her, for me. But if I didn't have a social work background, how do you work with that information? How do you set her up for success with the resources that she needs? Do you get back to her provider? All of those questions really come up a lot. So in this analysis that Deb did, and it was wonderful to work with Deb on all of these unmet needs from the food provider lens really just came to the surface. And then that community health worker role. We know that community health workers are trusted by their community. They have knowledge that others don't. They are going into the homes. They are having these conversations with folks. Our community health worker here in Rutland does a social determinants of health screening with all the patients. So she already knows what resources they might be looking for. So we've really identified that community health worker role is really such a great connector role between these food as medicine programs and the healthcare system. And right now we're in a pilot framework with this particular CHW and working with Katina Cummings. So I'm really excited to pass it off to Katina, who will talk more about community health workers.
Thank you, Emma, and thank you, Deb. It's just so exciting. We're really colleagues too. We pick up the phone, we talk to each other, we ask questions about systems. This is not just a one-time or two-time encounter for us to be together. So I appreciate both of you, your vision, and the work together, and we look forward to continuing that. Great to be here, and really appreciate the invitation. And I'm just going to follow up. Em and I met about 4 years ago, and we started talking about how her volunteers at the CSA pickups and her half-time staff were not equipped to what they were seeing in the community, the pain that they were seeing. So we know that people who are food insecure have varied and multiple and complex needs, usually. They face intersecting challenges, multiple chronic conditions, mental health struggles, and economic instability and hardship. Those are the top three. And that we also know that food availability is among the top social factors linked to race and health outcomes. So there are disparities as well in consuming and accessing healthy foods and knowing, again, how to use it for good health. I like to say in my training with individuals in the past, and by the way, at the time that so in the last few years, I should have introduced myself, right? I am in the last few years, I have been the Health is Wealth working with Health is Wealth Consulting. I am a strong, fierce CHW advocate. I'm a CHW trainer. Through a partnership with New Hampshire, Southern New Hampshire AHEC, in the last 3 years, we were able to train over 70 Vermont community health workers to join together with New Hampshire community health workers in core competencies, all of which, by the way, impact the food as medicine work that they do. And I'll talk more about that if I have time later. So we know there is no neutral encounter. We know this in social services and healthcare and even in the food sector, right? If somebody feels they're being listened to or somebody cares. In other words, these are not just drop-off situations. Emma had the vision to call and say, we know people have needs. How do we go beyond handing out the food? How do we go beyond into what other roles can we play in education and so forth? So I'm going to talk very quickly about community health workers. I'm dating myself here with this slide. Some of you might remember the Simon and Garfunkel song, Like a Bridge Over Troubled Waters. I created this slide because it's so telling on many levels. We won't have time to talk about it in full, but CHWs, or community health workers, are essential frontline public health workers. And they are the bridge over or the connective tissue between individuals, community, and health and social service systems. And those troubled waters are those complex conditions and the challenges that many of our people are facing who are food insecure. The waters are troubled as we have more people that are food insecure in our areas, especially rural areas, than we've seen in many years, as all of you know. So CHWs understand how to talk to people about health and well-being and the powerful forces and factors that shape individual and community health. And they understand that health is created when everyone is healthy together. They bridge providers, the theme of the bridge, to the culture, to cultures of their patients. They are connectors in multiple ways between individuals, community, and systems. CHWs, many people do not know there is a nationally recognized CHW definition, and it is a nationally recognized profession, community health workers. It's a frontline community health worker, as I mentioned a minute ago, who is a trusted member or has an unusually close understanding of the community served. This is from the American Public Health Association definition, which is used by many states across the country. The trusting relationship, and this is key because community health workers, the way I like to say it, they're of, for, and by their communities. They enable the worker to serve as that link, that liaison, that intermediary. And by the way, in Europe, they call them link workers. Just thought I'd throw that in. Between health, social services, and the community to facilitate access to services, improve quality, and cultural competence of service delivery. We must continue. We must deepen our understanding of food is medicine for quality care in our country and across our state. Next slide, please. So I'm not going to spend a lot of time on this, but I will say that on the right side, in case you have heard of many titles of community health workers, CHWs use that trusting relationship that enable them to serve as that liaison, as I mentioned, and they facilitate access to services to improve quality and linguistic competency of service delivery. But they go by many names, and you'll see a lot of them here on the right side. They're all under the community health worker umbrella. When we worked, and you'll hear about the 17 community health workers that were interviewed that Deb met with, many of them were called case managers. And after they participated in the 45-hour CHW training, they said, I'm really a community health worker. I'm in the community. I'm from my community. I do more than case management, but many times case managers serve, for example, as community health workers. Community engagement is rooted in cultural humility, empathy, and linguistic inclusivity. And CHWs embody person-centered, and I really want to stress that, person-centered, as Deb and Emma have highlighted today already, equitable whole person care. And what makes them unique is they do it across the lifeline. They work in tough environments, they work in people's homes, and they work in the community. And they often tackle the hard stuff, as Deb has alluded to. CHW core roles, there are many of them. I won't be able to go through all of them. You can see them here. Does this look familiar? Coaching, social support, care coordination. When I say does it look familiar, because we have food coaches already in this country and lifestyle coaches who are certified. CHW core roles that you see on the screen apply at the individual, group, organizational level, and community levels, even on the society levels. Yes, and financial coaching as well, absolutely. They sometimes provide direct services like screening services, blood pressure screenings, They implement individual assessments, care plans, and at the group level, they can engage from a particular priority population, such as clients from a homeless shelter, a youth group at a local church, or mothers at a local WIC nutrition clinic. I remember taking some food when we had the motel program for homeless people in Vermont for a number of years. And we were assigned to take, I was a volunteer at the time, and we took food to their hotel rooms. They couldn't cook the food. Some of the food that was given to them needed cooking, but they had microwaves but they didn't have refrigerators. So the fresh food that was given to them, that was provided to them, they had to eat immediately or discard. Okay, thank you. The next slide. So CHWs, this is probably the key message here. On why we think CHW roles and skills can bridge, I'm going to use that theme again, bridge the CSA movement, the food is medicine movement, to healthcare and social services. They are versatile and cross-sectoral, and this graphic depicts the uniqueness and versatility of community health workers, and they are integral parts of different but connected workforces. They have proven how integral they are to clinical, public health, and social systems. And you can see these systems here. CHWs are social care providers. They work in public health. They work in community-based settings and in home settings with a various range of organizations. They are part of the population health workforce, and they are part of the primary care workforce in many instances. Next slide, please. So in the study, in the research that Deb has performed, I worked with recruiting and discussing Deb's research with 17 community health workers across the state of Vermont in various settings. Over 8 of them, I think 8 of them, were from refugee, immigrant, and migrant backgrounds. We had many of them that were working in FQHCs and other healthcare settings. And then there were others in schools and other community-based settings as well. So it was a great mix of people in terms of their experience with food as medicine and the unmet needs in their communities. So in this slide, the research shows some of the unmet needs. Yes, thank you, Emma. I hate acronyms, and I did it, didn't I? I thank you for that, federally qualified health centers. I just wanted to share here some of the highlights of the research of what community health workers told Deb in those experience group. We're not just handling food, handing out food. We're helping people actually use it and see it as part of their care. So some of the findings from the foundational gaps include lack of formal recognition and integration of CHWs into clinical food as medicine teams, or if they are included, many of them, I will tell you, they tell me they don't have the opportunity to go out into the community, see people in their homes, go to the CSA sites like we're doing in our pilot project right now, and see clients directly. There is insufficient staffing, minimal funding for sustained FIM infrastructure, and so forth. But I'd want to highlight some of the challenges that are shared with community health workers in implementing food as medicine initiatives, and also just food insecurity in general. Many individuals need resources in language access. So the language and communication gaps with non-English speaking clients are huge. Also, there often is not attention to culturally appropriate foods, not only the foods themselves, but how people view how they cook it and how they eat it and how they use it. There are literacy and access issues for online ordering, and transportation barriers even prevent people from picking up their food. Why is this important? Because we found out from Emma and others and community health workers that the link isn't there. If someone doesn't appear for 3 weeks, right, to get their food, there's not typically a link in the healthcare, a community health worker or other individual to call up and say, oh, we miss you. We want to make sure you get your food. What problem or barrier do you have to getting it? That circle between the healthcare and FIM program, prescription program, that link and the work of the CSAs is not really present except occasionally and haphazardly and as organizations define what that looks like. And then finally, there are direct support needs, no standardized CHW training for FIM programs. CHWs do learn, by the way, training, and I'll get to that in a minute. They do have training on FIM, but very minimal, and lack of culturally relevant cooking education for clients. I want to give, if I have time, do I have
Actually,
time?
Katina, no, sorry,
Well,
you don't. But
okay.
I'm going to cover the next 2 slides and let people
Okay.
know, because I want to give people time to ask questions to you.
Okay.
And
Sure.
so if you have
Sure.
questions on the training and certification, it's interesting to note that there is no national certification and training, that each state or collection of states come up with their own types of training. And there is an opportunity within the specialized trainings that community health workers can access for them to be trained in the food coaching method.
And also yes, as part of the core competency training.
Yes.
And then I will just say, because there isn't time to go through these, but there are promising new state Medicaid strategies that can provide enrollee access to CHW services. The newest one is the last one, the 2024 physician fee schedule. So from Medicaid at the top of the screen to Medicare at the bottom, there are new tools under the physician fee schedule, 2 codes to address community health integration and for those that have long-term disability and conditions. So there's a lot happening nationally, and many providers and others do not know that they can bill for CHW services, even in food and nutrition under these codes.
Thank you, Katina. Take a deep breath. I know that was a sprint. And yeah, she's available to give much more information. If you ever invite her to give a talk, you can see how amazing she is. So I'm going to get back to the flow between these 2 systems that I brought up previously. And what I want you to know is that community health workers have already been embedded in food as medicine programs, and they've shown that they can improve food security and diet quality and chronic disease outcomes. As you can see, this is just a snapshot of recent studies using community health workers. And I know ROI is huge. So when we actually look at ROI, we see a positive ROI. If you can't pay for them in another way, like the Medicaid, Medicare payment, know that they can save anywhere from $2.47 to $11.20 per dollar spent for them. So there's a big, huge cost savings. And they do that by reducing hospitalizations, emergency care, and preventable utilization. And you've seen that before again and again when we're looking at the efficacy of these food as medicine interventions. All right. This was informed by the research, and this slide is ta-da! Yeah, I have to say that. Okay, this was a lot of work. And what the data informed was the clinician wants to be the gatekeeper. They are the ones the patients trust. They're the ones that say, you need this program. I am putting you in the EMR, and you are going, if indeed they agree to it, and you're going to be sent meals, groceries, or produce. If MMTs are needed, medical nutrition therapy, they are then referred to the dietitian. The clinicians are telling us they don't want to be nutritionists. And remember back to 1994 when they wanted to be the herbalist and the acupuncturist, right? We have some physicians wanting to know a deep level of nutrition. What I'm hoping is that they understand the difference between nutrition and food education, because on one side of the sphere in the healthcare, we're talking nutrition, but it's the food that the patient really needs to hear about. And yes to the training, yes to the nutrition training, but the clinicians and the dietitians won't be the chef training, doing the culinary skill building. They won't be the ones doing the at the elbow support. And why we know this is take a look at our healthcare system. They don't have the time. It's not that they don't want to do it. And what I love about it is their lives are going to change. They're going to be better prepared to counsel individuals when they learn how to cook themselves. So clinician to dietitian if needed. If not, it goes to this care coordinator. Now, this is super important. The care coordinator is the one that connects the medical system to the individual, but they need to connect the social determinants of health data with what food is given to them. And the reason I say this is we hear again and again with our study, they're giving my patient root vegetables. He has no teeth. My patient doesn't have the manual dexterity to chop vegetables. They just need frozen vegetables sent their way. That is a key. Provide just having the food show up on the doorstep without knowing the SDOH, the social determinants of health, and acknowledging an individual's palate and cultural heritage when it comes to food will mean that a lot of that food does not get eaten. That care coordinator then sends the patient into getting access to the food and also into the community for that education, for that culinary skill building, and they become the at the elbow support. They're the ones that need to know what's happening in that kitchen. I can't tell you enough, being a nutritionist for 30 years. When you ask someone if they eat a healthy diet and they say yes, oh Lordy Lord, that means a lot of different things to a lot of different people. Getting your eyeballs on what they have to work with, that's worth more than gold. And how about if we had a closed loop system? What if your food is medicine recipients, after they succeeded, got trained in food coaching and then went out into the community and became the change agent themselves? Wowza, wowza. Then you would have sustainable change. You wouldn't have to worry about this workforce. You're going to have individuals who speak the same language, and this is what I hear again and again. I want someone with this who speaks like me and looks like me to teach me how to cook, because that's where they feel comfortable, and we need to meet them where they're at. All right, food coaching. I hope by now you understand that culinary medicine's place in food is medicine is not on the side of the food is medicine pyramid. It is a foundational element, and without it, there will be no sustainability. And that if you do not honor a person's wallet, palate, and cultural heritage, you will not have sustainable change. And being able to see the patient as the solution, that is a game changer right there. And I hope a lot of you will consider this in your food is medicine programs. All right. The food coaching was built. I just didn't set something up, people, because food is medicine became a hit in like 1 or 2 years ago. I've been working on this for 30 years. In the early, like around 2005, I did a deep dive into how people learn and how they do behavior change. And they do so in discrete modules, discrete elements. They're learning spelling and then they're learning history, right? So I looked at the 2015 guidelines and I broke up the over 150 dietary recommendations, and yes, that's how many there were, into 9 to 10 modules. For the Food Coach Academy, I broke protein into animal sources and plant sources. And what we did was in Guilford, Connecticut, and I have a friend here, hello, Mary, who's from Guilford. And what we did was we said, what would happen if we messaged students one message a month? This month's all about fruit. The next month's all about vegetables. And what if we created one newsletter? And this was back in the day, the backpack, you had something go into the backpack instead of online. And we messaged the teachers and the parents on the front side, and the back side was to the kid. And oh, by the way, we left it at the pediatrician's office. So on checkout, you got to pick it up. What we saw through doing research with Yale's Rudd Center, the University of Connecticut stores, and Tufts was that knowledge, attitude, and behavior improved, and BMI Z-scores improved. Great. This modular approach to dietary change and teaching became the foundation of everything I did over the last 20 years. It became a foundational element of the Food Coach Academy. Fast forward, I was asked to open the Weight and Wellness Center at Dartmouth Hitchcock Medical Center in value-based medicine principles. Well, that didn't really happen. But they tried. They tried. Switching to value-based medicine, I know, is super hard. And I was asked to be part of the Teaching Kitchen Collaborative, which I'm sure a lot of you have heard about. And I was chair of best practices. I was the first chair of best practices, gathered around the first like 30 groups that were doing teaching kitchens. And we came to a conclusion that nobody had culinary competencies for nutrition recommendations. So I went to the TKC and said, hey, do you want to do a textbook? They chose not to do it at that time. And so what did I do, this stubborn Irish woman? Well, I went out and I did it myself. I spent my money. I had a lot of connections with people worldwide, gathered 40 international experts in everything from flavor to dietetics to medicine to behavioral change to motivational interviewing. And we created, culling over 2,500 articles, nutrition recommendations, but we didn't stop there. We then booted it over to a dozen chefs and said, chefs, if someone shows up in the kitchen, what is it they need to learn to do to eat more fruit or eat more vegetables? And so these culinary competencies are within this textbook series, and it is the foundational element that the Food Coach Academy is built on. Now, I get asked these questions a lot. Those of you that are dietitians, I need you to listen because I get in a lot of trouble when I do stuff like this, because I am not secretly training dietitians or nutritionists. I am training culinary skill builders. They take the prescription from you, the dietitian, nutritionist, or the physician, and they give support in terms of the prescription to what shows up at the end of that fork, plain and simple. They are trained in 3 areas: culinary nutrition, food coaching, and culinary medicine. This is the only school that teaches others. Now get this, we are not just teaching you how to cook, we're teaching you how to teach others to cook, which is a completely different ball of wax. It is very different to come in and say, well, I know how to cook this and I'm going to cook this. And yes, it'll have some impact, but it not matched with knowing how to parse out bite by bite changes will lead to overwhelm, and it won't lead to sustainability. And I'm going to give a shout out to Christiana Care Hospital and Fresh RX in Oklahoma. They are currently training community health workers as what I'm calling the Food Coach Tech, which is a much smaller program, as well as food coaches. The Food Coach Academy, the 1-year-long program, is certified by the American Culinary Federation. You get 510 continuing education hours, and there are 12 courses, 1 a month. Fruit's a different course than vegetables. We deep dive into taste and flavor because flavor is the change element here. And then Erin Martin at Fresh RX asked me to create something for the community health workers. And that's what the culinary medicine for produce prescriptions do. Now, people ask me this all the time too. Are you promoting, well, not beef. Now they're asking if I promote beef, but I don't promote beef. It's plant forward. It's not plant only. And the reason for this is I know that 5% of Americans are vegetarian and 3% are vegans. And if I, as a practitioner, tell you that is your goal, 95% of you are going to fail. And what good did that do either one of us? You as an individual, sacred goes in your mouth. You decide how far down that plant-based road you want to go. Every step you take will have positive consequences, and you are the owner of your own life. You get to choose when enough is enough. So this is Donita. She came to me because she wanted to teach Black and brown folk how to cook for their health. And as a student, once you learn the fruit chapter, you can go out and teach the fruit chapter. She had an NAACP in her local community center actually paying for her to go to school. All right. So here we go. That
Just
connector.
making sure you know you have less than 10 minutes left and we have an
I know. All right. So we solved this issue. We brought together the two. It's a system issue, and I've just solved it with my 2 colleagues in 40 minutes. If you want to get a hold of us, please reach out to us here. Please ask questions. I can't see the chat, so if you just want to start reading out questions, we are happy to answer them.